So let me introduce Mike Maier. Dr. Maier has been my partner for the past 8-9 years, and he's going to discuss ABCs of lower extremity wound assessment, which is very relevant given the last slide of Dr. Jaff.
So after a very sobering talk, obviously, one of the practical questions to ask ourselves is assessing lower extremity wounds, and that's the job I have in front of you in the next 5 to 7 minutes. So disclosures are as listed. So one of the most important things when it comes to assessing patients with wounds is to establish an accurate diagnosis, something that extends beyond really the scope of this talk, but that's the foundation with which we start. Then wound healing and assessing these wounds really becomes a balance of many different factors, certainly optimizing perfusion, as we've just heard, looking at features such as edema control, infection control, wound debridement, offloading, tissue moisture balance, and disease management for things like smoking cessation and diabetes. So in the interest of time, we'll focus on just a few of these. I'd be remiss if I didn't at least mention the bias of the meeting, obviously emphasizing that of perfusion assessments. So typically when we look at arterial ischemic ulceration, we see wounds with full thickness tissue loss. They have a well-circumscribed or punched out appearance, oftentimes with fibrinous or fibronecrotic bases, may or may not involve tissue loss over bony prominences, and are typically painful unless, of course, in diabetic patients in the presence of neuropathy. What you'll hear about later is sometimes what's referred to as the angiosome approach to wounds. The idea here is to optimize perfusion, direct inline flow specific to areas of tissue loss, and some would argue that this perhaps is becoming the standard of care. I'm biased because of my involvement with Dr. Shishaborn. He'll speak to that. But another area of assessing the ABCs of lower extremity wounds is that of edema and edema control. So we certainly know that's the case for things like venous stasis ulcerations, where venous hypertension plays a significant role. So compression therapy becomes mainstay. So we can use things such as layered wraps and uniboots to reduce volume, and we have patients come back with reduction in their volume and visible skin folds, and wounds improve. But that's not always the case, and sometimes this is almost a blind therapy for edema control. So, such as illustrated in a case here, a 51-year-old lady who comes in with painful medial ankle ulceration of nearly 8 months duration, and she had been treated with serial Uniboot applications once weekly throughout that entire 8-month period. But what she described was a sequential increase in size of the wound after every time she visited the wound clinic for sharp debridement. Now, she did have some venous insufficiency, but there are characteristics of the wound that suggest another disease process. So there's a raised violaceous border, there's circumferential undermining. She did have intact peripheral pulses, so no significant arterial components. But again, this foundation to establish an accurate diagnosis, this was a clinical example of Pyoderma Gangrenosum, for which the standard is not simple edema control, but a variety of different strategies, including immune modulating therapy and steroids. Now, what about patients with mixed arterial venous disease? I think you're going to hear about this later in this conference, but there's really a paucity of data when it comes to approaching these patients. So an example is pictured here, a 61-year-old lady with anterior shin ulcers of both mixed arterial and venous components. So angiographically, she did have tibial vessel disease, not amenable to intervention or bypass, but we opted to go after the venous component of disease based on wound location on the shin as opposed to the distal periphery. So we used some short stretch bandage systems and some clever tricks with topical wound care to facilitate healing of the satellite lesion, reduction in the proximal lesion, and ultimately after nearly 3 months, you can see that it's been a slow go with reduction in the size of the wound, but she's been compliant with her compression therapy as evidenced by the depression of the skin from that secondary dressing. So when it comes to patients with mixed disease, again, a paucity of data. So a small study by Musty, published a couple of years ago, looked at patients with mixed disease, an ABI falling between 0.5 and 0.8. You can see the absolute ankle systolic pressure greater than 60 or toe pressure greater than 30, but also with axial reflux in superficial, deep, or both venous systems. Patients were excluded, those with rest pain or neuropathy. Then arterial perfusion was measured with laser Doppler fluximetry, toe pressures, transcutaneous oximetry, and the venous return with calf muscle pump ejection fractions. Baseline characteristics are shown here. You can see these patients did in fact have a component of arterial disease both in the iliofemoral and femoral popliteal segments, But the interesting piece is when they used short-stretch bandage system to treat these patients with mixed disease, they did see an increase in the laser Doppler fluximetry as well as toe pressures in patients treated with both 20 to 30 millimeters of mercury compression as well as the 30 to 40 range. When they went above that, they did not see that same increase. So there is some data to suggest the benefit of compression when done in careful, controlled fashion in patients with mixed disease. So if that's the case, well, edema control has got to be a good thing for everyone with a venous component to it. But certainly a relevant teaching point is to examine the whole patient and get the whole picture. So clearly this man has some venous disease with the pigmentary changes in the leg. But what about ABCs of his wound assessment? He's already missing some digits. Let's take a look at the opposite limb and see how things have gone for him there. Not so well. Clearly, when we take a closer look at the foot, you can see he's got full thickness tissue loss in the lateral column, pressure ulceration on the heel, and obviously that critical history reveals multiple risk factors. So diabetic gentleman, renal transplant, multiple both upper and lower extremity revascularizations with tissue loss in both regions. So this is an example of critical limb ischemia, and here clearly no role for compression therapy in the acute phase. Now, what about infection in terms of addressing the assessment of lower extremity wounds? There are certainly hallmarks of infection we all learned back in training, those being erythema, calor, tissue edema, increased drainage. Pain, I put that with an asterisk because obviously that can be blocked in the setting of dense peripheral neuropathy and diabetes. Fluctuance in depth. It's important to remember also to assess wounds not with just our eyes but with our hands, such as pictured here, a diabetic midfoot ulceration with tracking between the two and deep probing to the level of bone. So in this case, superficial cultures become largely unreliable. Deep tissue cultures are important to guide therapy. Now, another pearl of assessment and management for these patients, not to leave dressings in place for extended periods of time. Oftentimes, companies will tell us that dressings are good for a certain period of time, but they may not be the case when it comes to practical clinical application. So, an example here of an absorptive dressing on a heel ulceration that was changed only once weekly as per package insert. But by simply altering that to daily application, a much healthier looking wound with no clinical critical colonization. Now, wound infection can also be assessed in terms of depth of tissue involvement with a variety of different imaging modalities to assess the extent of involvement. So what's pictured here is a patient who's had a fifth metatarsal head resection in the setting of previous ulceration, now with first metatarsal phalangeal joint osteomyelitis. We also can see that translated into the clinical setting in that diabetic patients have muted signs of infection. Here, an open partial first ray amputation. Radiographically, things look good in the acute phase, but when the patient comes back 3 months later for a follow-up after having stubbed their toe, we can see, unfortunately, serial radiographs demonstrate tissue loss extending to the bone level with osteomyelitis in both that residual first ray as well as the second metatarsal phalangeal joint. So now the patient's relegated to transmetatarsal amputation. So reflective of bias as a podiatrist, offloading becomes important for assessing these wounds to address things like pre-ulcerative callus, so we prevent the progression to neuropathic ulceration. And if, unfortunately, we do have patients with tissue loss, it goes without saying we need to pay attention to the opposite extremity so as not to have similar tissue loss. So offloading devices are wide and vary depending on ambulatory status and functional of the patient, and there are temporary versus long-term devices that can be used. So in conclusion, assessing patients with lower extremity tissue loss begins with that thorough history and physical exam to establish an accurate diagnosis. Then we have this balance of wound healing factors to address things such as arterial disease, edema, infection, and abnormal mechanics. Thank you.